sustainable, but I think speaks to the different ways that people interact with these technologies.
All right, thanks again, Matt. And with that, let's transition to the former co-director of the digital health course.
How crazy!
It's
It's crazy. It's so good to be back in this room, back in the Department of Psychiatry. And this is my first presentation at UCSF since I joined Hopelab as Director of Research Operations in August. And of course it was going to be this seminar. Thank you for inviting me. And it is very appropriate that Adrian and I are co-presenting today, and you will hear a little bit about how we are thinking about evaluating digital health interventions at Hopelab, and also using quantitative and qualitative data. In fact, the parallels are stronger than I had even realized. So I hope that you all will see those as well and maybe think about, I don't know, how we can learn from each other and all potentially work together. So I'd like to just make one comment about the fact that I am technically the industry speaker today, which feels a little funny because I'd like to give you all just a quick note about what Hopelab is. So we are officially a social innovation laboratory that is a nonprofit organization. And that's super important. So to the extent that that might technically make me a non-academic speaker, fair enough, but I'm a different kind of industry speaker than one who might be in a for-profit company. And I'll tell you a little bit more about that as we move forward in sharing really the breadth of work that Hopelab has been doing in the last 18 years. So I'm going to go broad and try to give you a flavor, a potpourri of sorts of the work we've been doing. And then if you'd like to know more about any specific project, please feel free to ask me after. So we officially call ourselves a social innovation laboratory, as I mentioned, and we focus on meeting behavioral science with human-centered design to make technological-based tools, everything from video games to, which you'll hear about today, to a chatbot product to apps, all in the name of supporting adolescent health and emotional well-being. So the main area in which we work is adolescent health. That was our legacy, and it is true today that all of the projects that we take on are meant to make measurable impact on the lives of young people. We also have a very strong legacy in behavioral science, and that started way before I got there in August of last year. It started, in fact, with our benefactor, Pam Omidyar. So Hopelab really was started with a single question from Pam that was, can a video game help cure cancer? Pam Omidyar is married to Pierre Omidyar, who founded eBay. And when eBay went public in the late 90s, in the first dot-com boom, Pam and Pierre found themselves to not only be one of the youngest billionaire families of the time, but also well poised to think about how to make social change in the world to impact areas that they cared about and that thought would be important for the future. Pam in particular was interested in working on the area of adolescent cancer survivorship. She had worked in an adolescent immunology lab in graduate school, and also she was a gamer. Pam and Pierre enjoyed playing video games together for a long time, and she knew how impactful and engaging they could be, certainly, and she thought, what if we created a video game that would address one of the many areas of particular concern around adolescent cancer survivorship. So Hopelab was born and was about 18 years ago, and until today, the operating budget is funded by the Omidyar Family Foundation. So one of the main problems in cancer survivorship in adolescence is around chemotherapy adherence. This is a set of chemotherapy medication. This is the number of pills that an average adolescent who is diagnosed with cancer needs to take one a day for 3 years, 1,095 pills. That is quite a lot of pills. Adherence is quite a challenge because not only do adolescents have to surely remember to take these every day, but they have quite a lot of negative side effects. And every day for 3 years, doing anything that often can be somewhat, frankly, painful. I mean, anyone who's trying to get a new habit, even something that makes us feel good, knows how hard that is. But in this case, they were very, very negative drawbacks. And in fact, the average adolescent who was meant to take this 3-year course of chemotherapy adheres at about 80%. So that's minus almost 300 pills from that regimen of 1,100. And that is directly associated with a higher incidence of cancer recurrence in this population. So Hopelab set out to address specifically the issue of chemotherapy adherence in their first product that was worked on for a good 4 or 5 years. Pam, who was actively involved in Hopelab and still sits on our board, worked together with behavioral scientists, primarily psychologists and neuroscientists, as well as a team of video game designers to build our first product, Remission, which is a first-person shooter game where teens can play the part of Roxy, who goes through the body of a teen with cancer, shoots chemotherapy into that body, kills cancer cells directly. But at Hopelab, we certainly don't stop with using behavioral science and theoretical underpinnings to understand how a video game might work, but we also evaluate all of our products with the rigors of science in a way that we would traditionally do so in the field of medicine and mental health with a randomized controlled trial. So there were a series of RCTs that were conducted on this first generation product of Remission. And here is an example of some data coming out of the largest RCT that had 1,375 adolescents who were diagnosed with cancer, recruited from 35 medical centers in the United States, in Canada, and in Australia. And they were randomized to one of 2 conditions. The control condition was sent a video game that mimicked this one. It was an Indiana Jones game, kind of active, had similar kinds of images as the Roxy game, and told to play daily for up to an hour for 3 months. Those in the remission condition also got the Indiana Jones game as well as remission, and were also told to play it an hour. I may have said an hour a day, I meant an hour a week, for up to 3 months. I'm sorry. It's that would have been quite a lot, especially for this time, which was in the early 2000s when this research was taking place. And we looked at outcomes related to chemotherapy adherence as well as cognitive mediators of adherence, things like self-efficacy, things like purpose, connection, and control. And here is what we found. After 3 months, those who were randomized to the remission gameplay had higher levels of chemotherapy metabolites in their blood compared to those who just got the Indiana Jones video game. And these were significant differences. They also had lower levels of missed doses of chemotherapy. So that's those pills I showed in the beginning were literally more full in the remission condition compared to those in the control condition. And then another important measure of adherence with respect to cancer treatment has to do with the antibiotics that adolescents are also supposed to take. And there were also significantly higher levels of antibiotic metabolites in the blood of those who were randomized to play remission. So the work that Pam set out to do was indeed shown to be effective. A video game could be directly linked to chemotherapy adherence and to antibiotics, which are a key combination that predicts whether cancer will come back and whether young people will die eventually of cancer. So that was very exciting for Hopelab, and frankly, it was such an incredible effort that was put into this game that a big question around how we would think about the future of this video game and continuing our work in cancer survivorship came up at that point. Now, the main trial, this 1,375 person trial, was published in Pediatrics, and please do take a look or ask me if you're interested in seeing that paper. That came out in 2008. And by then, we had this baby starting to come on the market, and the future of video games was, well, the then of video games was changing quite a bit. So remission continued to be evaluated in some degrees, and also the next generation of the product was developed. So I'll give you a sense of some of the ways that we paired neuroscience data to understand what was happening in the brain of teens who played remission, and then share the work that we're doing in the area currently. So there were some studies in partnership with a neuroscience lab at Stanford that showed that among teens who actively played remission, areas of the brain related to motivation, related to excitement, and related to memory were lighting up in adolescents who were playing the game. Interestingly, the control condition here was watching others play the game. So it's that YouTube style or Twitch style of seeing video games that is so popular now, and that is most parents, including my deepest fear, that kids are just going to be watching other people play video games. And indeed, this research showed that what seemed to be important as a function in brain change around playing remission was this active playing. It was not that passive watching, even of the same video game. So no, watching a behavioral intervention on Twitch is not necessarily going to have that same, at least changes in the brain compared to active play. And I can now officially tell my son that is back. So the future of remission ended up being an app that is available in the App Store now. But we aren't as actively supporting that product in the cancer survivorship space. And instead, we've gone a little bit more toward thinking about how to reach young people in the context of social media, and also to develop a tool that will engage young people after they have undergone treatment and it's over. So at Hopelab, one of the ways in which we carry out our model of being a social innovation lab is to partner behavioral science with human-centered design. And this is indeed the design that came out of the Stanford Design School. We have folks on our team who started at IDEO and are thinking about how to directly understand the lived experience of the patient population that we aim to help, and to make and deliver tools that will have meaning in these people's lives and that they will want to use. So we've got the theory, we've got the engagement with the population, and then we've got the evaluation about whether these tools work. And in the area of cancer survivorship now, when we were thinking about the next generation product, we actually went outside the video game space and kept and used our incredible legacy of working with teen cancer survivors to build a chatbot product. And this is actually very similar to some of the work Adrian's doing, so I can draw some parallels there as well. So in the last 5 years or so, when we thought about how we wanted to affect teen cancer survivors in the next iteration of our work, we wanted to address a key other high-risk area in the lives of young people with cancer, and that is coming back into their communities and into the world after they have undergone cancer treatment. So they're alive, and in many cases their cancer might be gone, but they're at extremely high risk for clinical depression, clinical anxiety, and suicidality at this time, because they've often been highly engaged with a hem-onc clinic. Most of those clinics have some kind of mental health, active treatment, and it's all been kind of dropped. So as we know, this is a time in the lives of young people when a lot of different mental health services aren't as available as they are when they're officially children. And this is certainly true for young people who have undergone cancer treatment as well. So we had a strong legacy in the area of positive psychology. We knew it could promote feelings of wellness and reduce depression and anxiety, and we wanted to see whether delivery of positive psychology skills in the context of a chatbot might be able to impact the lives of young people who had undergone cancer treatment. So meet Vivibot. This is our chatbot product that actively lives on Facebook Messenger. We started with Facebook Messenger for a number of reasons. The first is that at the time we were creating Vivibot, Facebook was and still is the social media platform with the most users overall compared to others. The other thing is that their messenger tool had the ability, bless you, to use some, take advantage of some capabilities around delivery of chatbot content that were more advanced than other social media programs like Twitter or Instagram or, of course, Snapchat at the time, which was just kind of coming on the scene. And still today, it allows us to have a more interactive experience with our users. But I'll save this question off of the past that we are thinking about adapting Vivibot for other social media platforms. So this is how you reach Vivibot. On the bottom left corner, you can literally type that into Facebook Messenger and start chatting with Vivibot right now. It or she exists actively, and anyone can, even though she is meant for young cancer survivors, anyone can connect with her at any time. We also have a webpage that can give you a little bit more information on the goals of what we're doing with Vivibot, if anyone should ask. And if you have any connections to teen cancer survivors, we certainly would hope that you could share the product, particularly with them. So here is the way that we're thinking about intervening in a chatbot context. So here's where I'll draw a little bit on what Adrian mentioned. Adrian talked a little bit about the capabilities of a text-based program, especially in the evaluation of kind of simple interactive experiences with rating scales like mood ratings. So on the left, you'll see that we actively use mood ratings in the context of Vivibot as well. Fairly simple Likert type scales that ask people how they're feeling. We ask about 6 different moods every day among people who are chatting with Vivibot. And this is as easy, if not easier, to deliver than it is in the context of a text type format. But you can do a little bit more in a chatbot, even that isn't smart. So we don't have an AI-based program. She can't interpret what people say and then deliver content directly yet. We'd love to get there one day. But until then, we're just delivering content and giving some kind of multiple choice based buttons, things like what would you like to see now, and people can choose. So in the middle, we've integrated videos directly from our adolescent cancer survivor panel of people who helped us develop the content and also the language and the framing for Vivibot. So these young cancer survivors made videos that both normalize the experience of having depression and anxiety among cancer survivors and also show them practicing the direct skills that we're trying to have users work on. And then on the right, you see guided reflection as an example of where we're eliciting qualitative, interactive data from users. And this is just a lot richer than what can be done in a text message format. So sometimes people can go on for quite a long period of time in this frame. So we use a positive psychology framework to deliver 7 different skills that have been shown to be effective in other primarily adult populations with serious illness. So this is based on Martin Seligman's positive psychology theory and a manual that was developed by Judy Moskowitz, who was here in the UCSF Department of Psychiatry on faculty for a number of years and is now at Northwestern. So Judy has worked with adults with HIV as well as adults with cancer and other serious illness to deliver this particular formula of 7 different skills. And it seems like all 7 are important and impactful in making lasting changes around health and well-being. They have never been tested directly in adolescents with a serious health problem, certainly like cancer, or in the context of a chatbot. So I mentioned that Vivibot is available. We are actively hoping that young cancer survivors or others who are interested in getting these positive psychology skills can benefit from these skills directly, and also that they can help us improve the product. However, we're also using that randomized trial format to try to formally understand whether engagement with Vivibot is associated with some of the mental health and other cognitive impacts that we hope engagement would change. So this is a very busy slide, and I just want to give you a sense that we are actively running a small pilot trial with young cancer survivors to evaluate effects on depression scores, anxiety scores, and positive and negative affect, as well as things like self-efficacy, purpose, connection, and control, which are directly related to these symptoms. So again, I know you can't see all these details, but we are recruiting for this trial with, or we just finished recruitment with young people who have finished cancer treatment within the past year. We're recruiting directly within the chatbot. So if you go and interact with the chatbot, you'll see a question about whether you'd like to be evaluated for screened for participation in a trial, or you would have up till 2 months ago when we stopped recruitment. Then those who are interested sign consent and complete a baseline survey outside on Qualtrics, and then they're randomized to one of two conditions. The experimental group got direct immediate access to all of Vivibot's chatbot content that I just showed you, all 7 skills and all of the types of content that is available on Vivibot. Then we have follow-up at 2 and 4 weeks. I didn't mention yet that Vivibot is designed to deliver 28 days of content, and the 7 skills are randomly shown to people. It doesn't matter what order, at least not from what we've seen thus far in the literature. We will be able to test that though. Those who are in a waitlist control group are told that they will only get daily mood ratings for the first 4 weeks, and after week 4, they will get access to the full chatbot content. What this does from a design perspective and thinking about designing small end digital health interventions is that we're able at 4 weeks to look at the main outcome differences on depression, anxiety, and positive and negative affect. But then at 8 weeks, we still have those in the control condition, a full 51 people who have actively interacted with the full content of Vivibot, and we can look at engagement measures like which particular skills people engage with and how they're using the bot specifically. And I will also draw attention to something Adrian mentioned, that just engaging with mood ratings is pretty impactful, right? You showed that with your CBT work and your text message intervention. So note that our control condition in this trial is very active. And we were a little bit worried about that at the outset, in addition to the fairly small n. But we're just looking to see whether it looks like Vivibot can move the needle on some of the things we hoped that it would. And I'm so excited to have had this very early data available to share with you all today. This is not yet published, but we were able to just take a very brief look at the main outcomes for today. And we have some real promising findings with respect to anxiety. So on the left, we've got baseline scores in the control group in gray and the treatment group in blue on the NIH PROMIS anxiety scale, and that is T-scores here. And we see there's a very slight but non-significant difference in anxiety scores between experimental and control at baseline. And then there was a trend at P.09 toward an interaction effect in time by group, such that those who got the full Vivibot content had lower anxiety at week 4 compared to those who only got the daily mood ratings. And that's a meaningful difference. So to give you a sense of T-scores on the PROMIS, that level in the experimental group, a little bit below 65 at baseline, that's a bordering on the severe level of depression, and they're getting down to moderate by week 4. So in a really short time, that is a fairly decent reduction among just 25 people. And just looking at the data a slightly different way, on the right, those are differences between baseline and week 2 scores in the first set of boxes, and then week 4 scores in the second set of boxes. And you can see that anxiety is reduced among those who actually got the full content, but it increases slightly among those who just got mood ratings. So to give you a sense of the effect size, which is -0.41 here, that's something we look at in a trial with such a small n. That's a really nice effect size. And frankly, it's similar to what we've seen in a couple other chatbot studies, including the trial that's published in JMIR Mental Health, I think, on Wobot. So that was really promising, and we're looking to try to get this data out more widely and try to unpack a little bit about what this is about next. And I wanted to also share something Adrian also shared, which is the rich qualitative feedback that we're getting about how Vivibot is causing and related to meaning in the lives of its users. So these are answers to the question, what do you like about Vivibot? And I won't read these to you, but just give you a moment to get a sense of what young people are saying about what it's like to interact with Vivibot. We didn't have enough diversity with respect to ethnicity to really unpack some of the interesting things that you are thinking about around individualistic and collective cultural values and how people are talking about use of Vivibot, but we absolutely have a snapshot of a certain age and how young people are feeling connected to this thing that similarly they know is technically a bot. It's made very clear from moment one that there isn't a person on the other end. And while we do have a way to analyze whether language reflects certain risk, getting to the question that you asked Adrian earlier, Erin, and we do mention that if they do reflect certain risky terms, we will potentially intervene and we give them the crisis text line number if they do have risk. Otherwise, they are reflecting this feeling that someone is listening, that something is listening, and that feels so meaningful for them, even though they know it's not a person. So there absolutely is something there for these young people, and that's what we were hoping when we developed this product. So I'd like to shift gears a little bit and share another project that we're working on at Hopelab, and I hope to have time to do two other quick snapshots. The first is a project that's at a much earlier phase of work than Vivibot, where we are thinking about building a technological tool to address loneliness among college students. Loneliness among young people is at epidemic proportions, and it is directly linked to things that we're hearing from college administrators, from mental health professionals, from parents, and from young people themselves are at highest rates of any generation, including clinical anxiety, clinical depression, suicidality, and completed suicides. This is absolutely preaching to the choir here. I know many people in this room are very aware of this. But loneliness in particular is unique because it's often framed as a problem of older adults. And interventions are often framed as something that we need to conduct in the context of getting social experiences to older adults who are isolated, living at home, etc. Around young people, it's not framed as that big of a problem. So we set out about a year ago to truly understand and frame the extent of the problem among of loneliness among college students, to understand how best we might be able to intervene. So to give you a sense of the scope of the problem, this is a national survey conducted by the ACHA, National College Health Assessment, it's called, that found 30% of college students in the United States reported feeling very lonely in the past 2 weeks, and almost 2/3 reported feeling very lonely in the last year. So that's quite a large number. Our interviews with college administrators and those who work at student health services corroborated these kinds of findings of the extent of the problem. So we are directly looking to impact loneliness from a number of different frames that I think will be familiar, especially to those of you in the room who are clinicians and who are thinking about especially a cognitive and behavioral framework to understand how we address anxiety and depression among adults and adolescents alike. So we're framing loneliness as both a challenge as well as an opportunity. So on the left is our one conceptualization of how loneliness is a particularly challenging problem among college students in the US today. Those who feel lonely tend to associate that loneliness with low self-efficacy, that they can do anything about that problem. So feelings of, can I address this? I get to college, I'm feeling lonely, it's really hard for me to make friends, let's say. And there's this feeling that I can't do much about it. And in turn, they might be more likely to take a guarded approach to social situations. So walking into a dining hall instead of with their eyes up, buried into their phones, or deciding not to go to that dining hall and just getting something delivered, which is so easy in today's tech world, right? And that leads to a perpetuation of that guarded approach by automatic thoughts related to criticism, negative self-talk, as well as a lower likelihood that they'll go into social situations with an open approach in the future. Very similar to the CBT framework we think about with depression. However, we also notice some real pearls around some opportunities if we can change the frame at which young people are addressing social situations. So if people believe that they can do something, we're also noticing that they're more likely to jump into social situations with an open approach, both cognitively, things like I can handle this, cognitively in the way of addressing setbacks with compassion. This is okay, this is really hard, it's not easy for most people to be making friends in college. And then that is in turn associated with a greater likelihood that they will take social risks and be able to make more social connections in the future. So the work that we're doing is framed by 6 design principles that came directly out of that theoretical framework that I just showed you, as well as those extensive interviews that we've conducted over the last year. And here they are. They're framing loneliness as a growth opportunity, not a deficit, which is partly grounded in Carol Dweck's growth mindsets work. Giving people choices to participate at all in the intervention, but also multiple opportunities to make social connections. So not just delivering a forced intervention, which happens so often at college, especially in the early orientation stage. This is the social thing that we want everybody to participate in. And that was clearly something that students did not want to have in the context of this particular intervention. Finding that particular edge of discomfort that will allow for a nudge, something that would make people feel uncomfortable, which was okay with trying something, literally taking a risk when they're not so sure what the outcome would be, but not immediately flooding people with an overwhelming risk-taking situation that would mean that they would not want to go into it at all. And very similar to how we would think about treating somebody with clinical anxiety. Literally flooding is an intervention we'd use, but you don't start with the maximum fear stimulus, right? You go in a graded situation. So very similar there. And going directly to where students already are. So this means physically and literally where students are hanging out, but also in places where they value. And so this could be social situations on a technology-based tool to begin with, or places where people value and where they're spending their time on activities that they like. Celebrating efforts over results is a 5th principle, and also very much grounded in Dweck's growth mindsets. So we know that if people frame efforts, we're trying to change anything, if you frame it as effort goals rather than achievement goals, it makes it more likely that they will actually physically try something new. And then underlying all of our work at Hopelab is appealing to a greater sense of purpose. And we've seen with young people that if they're connected to a sense of purpose in the intervention, that it's more likely that they'll be interested in trying something, and maybe making social connections where you have a shared sense of purpose will be more meaningful in their lives. So we are actively heads down, literally right now, in the process of prototyping a tech-based intervention, probably going to be an app, in partnership with an organization called Grit Digital Health, which has a platform called You at College, which delivers a series of wellness opportunities that are specific to a particular college experience. So Grit will eventually inherit the product that we are making, and we're also co-developing it with them. They're doing the engineering, we're bringing the design, the behavioral science, the writing the tool itself. So I hope to be able to have both that tool developed and to be able to share more about what that is and some early pilot data in the fall. So stay tuned. And lastly, I really wanted to make sure I had the last couple minutes to share another area of what we do at Hopelab. This is also related to the area of teen mental health. And it ends with a bit of a plea, because at Hopelab, we are a lab that makes things and we also evaluate them, but we can't even begin to do everything.
I found this on.
Siri wants to know what I'm going to say next. We can't even begin to do everything that we do without formal partnerships with academia. And here's an example of a survey we conducted in which we have more data than we could ever imagine analyzing ourselves. So we are certainly looking for partners, and if this area interests anyone, please do contact me after. So we know that social media and technology-based tools are ubiquitous in the lives of young people. And a lot of the data that existed in the national survey, places like Pew, Internet and American Life Project surveys, were fairly simplified and limited, especially in what it assesses around teens. So we partnered with the Wellbeing Trust, based in the East Bay, to commission a nationally representative survey of teens and young adults and their use of digital tools and social media. And the first report just came out in December. Please take a look at the full report that is available on our Hopelab website. You can just go to hopelab.org and it's on the front page, but here's a full link if anyone is interested. And you'll get a sense of how we were just able to scratch the surface of what data were available. But we were able to survey 1,337 young people between the ages of 14 and 22. The other unique thing about this survey compared to others available is that we've got a lot of quantitative data about what and how they're using apps and social media, but we also have rich qualitative data about the nature of their interaction with social media, as well as clinical measures of depression, anxiety, common measure of loneliness, and some other scales that might be interesting to those of you in an academic medical setting in psychiatry. So to give you a very quick snapshot into the way we looked at this first effort in the report, we focused primarily on teens who are depressed compared to those who are not depressed, to try to delve into the relationship between depression and use of social media. And one finding was that teens who are depressed honestly have kind of a double bind. There are, again, some opportunities around social media and some challenges. So first, the opportunities. Depressed teens, compared to those who are not depressed, are more likely to use social media for creative expression and for social support, and they're feeling like that's working well. They're more likely to say that they can express themselves creatively and feel less alone through their use of social media, whatever that looks like. And it's often daily use, to give you the upshot of the frequency. However, there is some clear challenge in what they believe they're getting out of that use of social media. So compared to those who are not depressed, depressed teens feel less supported by the content that they do produce on social media. So they say they get fewer positive comments, more negative comments, and are less likely to get any feedback, which of course could make people feel even sadder than when they first published on social media, or when they first posted. So unfortunately, I didn't have a chance to show you any of the rich qualitative feedback, but a lot of that is in the report. And I'll end by just sharing a set of areas that this report also covered, much of which we haven't even really began to analyze. So if you know, if you're interested in looking at any of these areas, or if you know someone or have a trainee who might be interested in looking at it, please let me know. And with that, I will say thank you so much. It's been a pleasure to share what we're doing with you.